Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Louw.
And I'm Louw QA.
Welcome to the Thinking Practitioner. Hi, this is Whitney Louw, and ABMP is proud to sponsor the Thinking Practitioner Podcast. ABMP membership gives massage therapists and body workers exceptional liability insurance, numerous discounts, and great resources to help you thrive, like their ABMP podcast, which is available at abmp.com/podcasts or wherever you happen to listen.
Even if you're not a member, you can get free access to Massage and Bodywork magazine, where Whitney and I, Louw QA, are frequent contributors, and special offers for Thinking Practitioner listeners at abmp.com/thinking. Hey, Whitney, how you doing there?
Very well, sir. How are you doing today?
I'm also good. I've been looking forward to our conversation. This is a perennial topic, you could say. This is something that, one of those that doesn't seem to go away, even though it's at different times some of us wished it would, maybe. I don't know about you.
Yes.
Maybe I'm speaking for myself.
Mhm.
But I've actually been looking forward to the topic because I want to get your take on it. And I got a couple updated ideas I want to share too. What are we talking about today, Whitney?
I believe we're talking about the iliotibial band today. So
Oh, yeah.
fascinating
same page there.
facets of the ITB.
And so it's fascinating facets. And there are some controversies around it, I think. What would you say about that? What are those, Whitney?
Yeah, if you kind of cruise through some of the social media posts, the research literature, and the buzz around the ITB, you're likely to come across some significant disagreements and debates around there. There are some controversies around the ITB. There's, for example, I think some of this emanates out of the fact that just comes from palpatory analysis of the fact that we're always taught as manual therapists to try to soften tissues all the time. And the ITB feels really hard most of the time on people. So there's
There you go.
controversies around, can we stretch it? Can we make it softer? Can we elongate it with manual therapy? Those are some of the things that we hear a lot about.
Yeah, is it even physically possible, you're asking?
Yeah.
And you're also saying something interesting. You're saying that just because we feel something hard as manual therapists in our hand, can we soften it? And I think you're implying, should we?
Yeah,
Even.
that's a big question. For years, I know early on when I was taught a lot about this stuff, and I kind of taught some of this early on too, was this idea of like, well, we're working on the soft tissues of the body, so they should be soft, right? And the reality is some of them aren't meant to be soft. And I fall on the side of the fence that's saying, I think we've been overdoing it with trying to do things to the iliotibial band.
You draw a hard line around that, do you?
Yeah. So,
Around softening.
mhm.
But in any case, there's also the fact that for massage therapists, other sorts of manual therapists, for sure, we feel things, quote, soften with our hands, and people feel better. And
Yeah.
it's just on a really simplistic, maybe almost unconscious level, we start to assume, and I think a lot of our models did or have assumed, that just softening it is improving it.
Yeah. Right.
And then so that leads to that thing you were talking about, like if I feel something hard, then it's a problem and I should soften it. So yeah, the controversies are, can we and should we?
Mm-hmm. And I think a question that comes up that, certainly came up for me, and we'll explore this in a little bit more detail when we look at this anatomically. I've sort of wondered years down the road, when we felt changes in that aspect of the lateral thigh when we were working at it, did we actually even change the iliotibial band, or are we changing the vastus lateralis, which goes all the way underneath it? And it definitely is a tissue much more responsive to changes in sensation than we might be feeling in the
vastus
iliotibial band.
lateralis underneath
Yeah.
it, the foundation, the muscular foundation we're feeling underneath that. Interesting.
Yeah.
And then our guest last episode, Robert Schleip, talked about this some. He gave a couple of views on what might be happening when it feels softening. He also described it, interestingly, as a North American social media controversy.
Yeah, which I thought that was interesting. So,
I had to chuckle. And I think there's something to that, perhaps, that certainly is controversial on social media. I think maybe that might extend to our friends in Australia, because I know that's been controversial there as well.
yeah,
But I think probably there are certain subcultures where these questions are more hotly debated than others, perhaps. Put it that way.
yeah. That certainly could be.
Okay, so what and we're gonna share our views on those controversies, I think, as we go along. Is that right? Because
Yeah.
I wanna hear what you think about that.
Yeah.
But do you wanna tell us something about what it is first? What is that iliotibial band?
Yeah. So, an interesting thing I noticed for me, this was really um, one of the most fascinating things that I sort of learned and first saw the first time I was in a cadaver lab. I was quite astonished and taken aback by how thin the iliotibial band is
Mm,
in a lot of people because the anatomy books with a number of different things, but the anatomy books can sometimes tend to mislead us a little bit about what things really look like because it always is illustrated as this big, thick mass going down the side of the thigh. And, I was quite surprised how thin it actually is.
a discrete band of fibers that has
Yeah.
color different than things around it is how it looks in, say, Netter or things like that.
Yeah. And that's one of the things that I think leads to the first thing that I want to talk about misunderstanding in relation to the iliotibial band or maybe lack of understanding around it is that it isn't really so much a discrete band by itself, but it is actually part of a cylinder of fascial connective tissue that surrounds the entire thigh called the fascia lata. And so there really is you really want to think about it as like maybe one section of the sidewall of this cylinder, which is a lot thicker, but it's part of that whole connective tissue cylinder surrounding the thigh. So,
Like a stocking or like a
yeah,
wrapping of the leg, and then the
yeah,
iliotibial band would be the fibrous portion of it.
yeah, I like that analogy. So maybe you got a stocking and you spray some, sticky kind of firm stuff on one side of the stocking, and it gets stiffer and stronger than the rest of the soft stocking around there. So,
Nice.
um,
Is it fluorescent colored, the stuff we're spraying on our
oh
stockings?
yeah,
Or
yeah,
okay,
that's right. And the
I like
IT
it.
band is also fluorescent. You may not know this, but you can glow it in
That's
the dark sometimes.
that's why we can see it so well in dissection.
Right? Yeah. Okay.
Now, are you
All right.
familiar with the idea that the
Caveat that is not true for any dentistry, please.
speak for yourself.
That's right.
So anyway, are you familiar with this idea that the iliotibial band is a T-shaped structure and seen in cross section?
No, tell me about that. Not
Well, I got to pull up the reference and I'll put it in the show notes because I know that this was an actual
Oh,
study.
yeah, we talking about, like, the anatomical attachments, like, to the linea aspera down the femur and everything like
Correct.
that
That's
crossing
right.
yeah, tell us
That's
about
right.
that. Yeah.
Well, it's basically, again, we think about it as a stripe painted on the side of our stocking.
Mhm.
But if you do a cross section of the femur, you can see that it actually is contiguous with the septum that goes down between the muscles and attaches to the femur along
Yeah,
its whole length. So it's not
right.
just like a discrete band floating out there on the edge of your thigh. It's actually a T-shaped structure that's attached to the femur for
Yeah,
its whole length.
yeah. And interestingly, a couple of the resources that I was reading, some stuff on iliotibial bands spoke about the upper portion of it acting more tendinous and the lower portion of it acting more ligamentous. So, for example, as you noted, the connections over to the femur may have a lot more to do with transmission of forces from gluteus maximus and tensor fascia lata to the femur in the upper portion of the thigh, and the lower portion of the IT band acting more like a ligament in
A knee
stabilizing the
ligament.
knee, during his
Nice.
various activities, which we're gonna get into in a little bit. But yeah, that's fascinating as well.
Yes, and then I've actually read the opposite, where they wonder about. I think you're going to tell us some about pain around the lateral knee, that being due to, say, tendon-like responses in the iliotibial band itself, as well as some other things around it, which I hope you'll tell us about as well.
Yeah. So, what else here on anatomical things? So generally in most anatomy books, the distal attachment of the iliotibial band is noted as Gerdy's tubercle on the tibia. Gerdy, Gerdy, Gerdy's tubercle on the tibia. Hey, do you know who Gerdy was, by the way?
You got me, and that's
Oh, you
again.
got
This
me too. I don't
is
know. I was just curious if you knew,
well,
but
and this is different than what I just said about it being
yeah,
attached to the whole length. You're saying that there
yeah,
is a classical attachment you can look up, Gerdy's tubercle on the tibia, and it's uh, the distal
yeah,
end of that, obviously, which it attaches on across the
right.
knee.
Yeah.
Okay.
So we would consider that as probably one place where a bunch of the lower portions of the IT band attach. But as you noted, that's not the only place at all. It's along the whole length of the femur. There's connections into the femur itself, as well as there are fascial connections in with some of the patellar retinaculum. So we got to remember these things aren't just one small discrete location, but there's other ways in which those forces are dispersed along the length of that iliotibial band to other adjacent structures there.
Things are connected, especially
Yeah.
as we start to talk about. I mean, it's interesting. The iliotibial band is a fascial structure that has a
Mhm.
name. There are fewer of those, perhaps, than muscles. I wonder if we added up the number of named fascial structures and the named muscles, how they
I
would
think it would
compare.
be far less than the number of muscles,
Yeah, thank
probably.
you
Yeah,
for
yeah,
confirming my guess
yeah,
around that. So, but that's the problem with naming fascial structures. Of course, they're connective tissue, and so they connect to everything.
yeah,
And it's hard to draw the line and say, okay, here's where this starts and it stops.
yeah. And hopefully, as we delve deeper into some biomechanical research in the future, we can one of the things that I've always been fascinated with as we look at all these connections is having a better understanding of what percentage of load is transmitted to all of these different places. So, for example, you talk about Gertie's tubercle being the main location where the IT band connects. But if you look at some of the biomechanical studies about the function of iliotibial band, they're talking about tensile loads changing with different angles of knee flexion. So it's more on the anterior fibers in certain knee positions and more on the posterior fibers in other knee positions. So um, curious
Yes.
to know more about that as we learn more about the function of those connective tissues.
And you're talking about knee positions, meaning degree of flexion or extension of the knee?
Yeah. Hmm.
Okay, because then there's abduction, adduction of the hip too, which is
Yeah.
thought to change the forces going through that structure.
Yep, absolutely. As does, knee positions. And I think you'll mention a few things about this too with genu valgum and genu varum, the knock-kneed or bow-legged position. So if you imagine, in particular, a bow-legged individual, which is referred to as genu varum, that IT band is a bit more bowstrung around the outside edge of the thigh and knee in a genu varum position. Excuse me, yeah, a genu varum position than
Mhm,
the bow-legged position. So
mhm.
those static positions, in addition to gait mechanics, can certainly have an effect on ITB uh, force
Well,
distribution.
is it time to bring in a point of view yet?
Yeah, let's do.
Uh, so what you're saying there is the bowstrung idea that
Mm,
if you're knock-kneed or bow-legged, your iliotibial band will have a different tension to it or have a different contributor there.
mhm,
With the idea that if it's tight, it might actually bow your leg sideways and give you like a valgus pattern, like a knock-kneed pattern.
mhm.
I assumed that. As rolfers especially, we were really looking at what didn't lengthen, what was short, and how that tensegrity model of the tension and compression forces could be balancing out across a joint like the knee. There's something to that. And yet, it has liberated my thinking and helped me drop another level in my understanding, I think, to question that assumption. To say
Mhm,
that just because a knee is valgus, is that iliotibial band tighter, in quotes.
mhm. Yeah,
And then that dovetails with the question of like, should we even stretch it? The other point of view being, well, maybe if it's tight, it's because it's helpful for it to be, quote, tight. Maybe it's a spring more than, say, a muscle that's not relaxing.
yeah, and in fact, a number of the studies that are looking at iliotibial band function say that it does appear to be playing a very prominent role in knee stability during certain phases of gait, especially in the deceleration phases of the stance portion of gait. So
That makes a whole
that
lot of sense to me.
yeah, that seems to reinforce the idea that it's really meant to be tight with tension on it to help in stabilizing the knee in certain activities.
It makes sense to me because I was just walking down a steep mountain with a backpack on
Hmm.
and stepped around a bush and did a funny little thing and kind of almost went down into my knees and had to decelerate that forced kneeling thing. And
Yeah,
that's like right where I felt it, right in that
yeah,
lateral knee thing. So it
yeah.
was like helping me stabilize that moment in time.
I'm curious, after that point, did you continue to have discomfort in that knee as you continued to go downhill?
It was sensitized. I could,
Yeah,
I kind of walked it off as it were, but I could feel like, okay, that got a little unhappy, minor strain or a little aggravation in there.
yeah,
No lasting effects at all, but it definitely lit it up in my awareness for a little while.
yeah. I had another interesting hill walking story, ITB friction, and we'll talk about this problem a little bit later on here. But lateral knee pain with the ITB, as we noted, is frequently associated with either running or walking activities, but especially the deceleration phase going downhill.
Yeah.
And I was hiking with a friend of mine. We were hiking up South Sister, which is a mountain nearby us, about 10,000 feet. So it's a pretty good climb up there. And we were no longer spring chickens. We were a little bit farther down the road of aged
What season of
experience.
chicken were
That's
were
right.
you?
I'm thinking when this happened, I was probably mid to late 40s or something like that. My friend was a little bit older than me. So
Yeah.
anyway, we hiked up the mountain, and on the way down, he began to have just a screaming case of ITB friction syndrome, lateral knee pain.
Uh,
And I had learned this in a orthopedic clinic when I was working years ago. And I said to this guy, look, I know this is going to sound really weird, and you're probably going to tell me I'm a nutcase for doing this and trying to do that. But if you want to get down this hill without as much severe knee pain, if you walk backwards, you won't feel that knee pain because it changes the mechanics of the way it loads the IT band. And he
yeah.
did walk probably halfway down the rest of this mountain backwards.
If it hurts,
'Cause
you would.
yeah,
Did you have him
and
put his
so
backpack on his front?
luckily we were just day hiking, so yeah, he
Okay,
wasn't carrying a load, wasn't carrying a heavy
that's
backpack,
good.
but yeah.
No, that would totally change the dynamics, wouldn't it?
Yeah, so, if you're a person with ITB friction or lateral knee pain from iliotibial band and you're wanting to continue your activities, just turn around and do it backwards. It may change it for you.
I
But
mean, you know a lot about this ITB friction thing. Do you wanna jump into that, or is there anything more you wanna tell us about?
yeah, so
Uh,
I think we kinda covered a lot of the main things that we were, focusing on with anatomy. So let's talk about some of those things that how the ITB is frequently involved with certain types of pain complaints. So I keep mentioning this thing with ITB friction syndrome. It is a condition that does tend to affect quite a number of people, especially if you're runners or doing active work. Some of the studies about it indicated anywhere from 12 to 16%. I saw as numbers for the number of people who develop this lateral knee pain from iliotibial band involvement in people who are runners. So a pretty common thing. It's often reported as like the second most common running overuse injury. So
okay, so now,
yeah.
that's just to throw in a assumption of mine, not based on much. I work here in the Boulder area, and we have a lot of athletes, a lot of runners,
Hmm.
and I somewhere got the idea that it's mileage dependent, that you get it more frequently in high mileage runners. It's more common, say, in marathoners than others, and that in my estimation, it's not that common anybody else.
Uh-huh.
That seems to be a high mileage runner thing. Does that fit with what you know,
I
or
don't know if that is supported by the literature of how frequently it occurs, but that would make sense to me because it does tend to be an overuse injury of repetitive loading on those structures. So the longer your mileage is, it would seem the more likely you would be to develop that.
people don't, get it sitting around listening to podcasts, for example?
Tend to not do that, yeah, unless they're
Alright.
in a very awkward chair position and leaning on their lateral knee region and
We
irritating
should
that.
do
So,
we should do an episode on podcast injuries or
uh-huh.
podcast risks.
Yeah, that'd be a
Anyway,
a good one. So, yeah.
this one won't be on the list, so let's make sure we cover it today. What else about ITB friction syndrome?
Yeah, so a couple other things here, and this kinda goes back to anatomy for just a second. The iliotibial band friction, historically was somewhat blamed on irritation of a bursa underneath the distal iliotibial band. So there was suggestion that there was a bursa that was getting squeezed between the distal iliotibial band and the lateral epicondyle of the femur during repeated flexion and extension movements. So during flexion and extension, the iliotibial band would rub back and forth across that lateral epicondyle of the femur,
Yeah.
and the bursa underneath there would become inflamed and irritated.
Mhm,
But a couple of recent anatomical studies have called that into question,
mhm,
saying that they, in fact, did not find a true bursa underneath
mhm,
the
mhm.
distal iliotibial band, but instead found a fat pad under there, which tended to be richly innervated. And it was an irritation of that sensitized fat pad that was likely causing some of the lateral knee pain from the activities there.
There was a lot about this, say, 5, 6 years ago when this was coming out. Does that change the way you approach it at all, Whitney? If
Not
it was
really,
or
because
wasn't a bursa?
my perspective on addressing this is still kind of the same of like, let's see what we can do to reduce the load on there. So,
Yeah.
um, one of the things that's interesting for uh, for understanding some of the more fine points of the biomechanics there is a recognition and understanding of something called the screw home mechanism of the knee.
Mm,
So when you move your knee in flexion and extension, it isn't a pure sagittal plane movement of just moving straight forward and back. And this has to do with the difference in size of the femoral condyles, with the
mhm.
medial condyle of the femur being a little bit larger than the lateral femoral condyle. And as a result of that, during the very end of extension, usually about the last 30 degrees of extension, the tibia rotates externally and it sort of
Mhm.
locks into position. And we call that the screw home mechanism. So, at,
External rotation on extension, the 2 E's,
yes.
that's how I
And
remember it.
again, to clarify, that is external rotation of the tibia
Yeah.
in relation to the femur in what we call an open chain position, which means the
Aha,
body is not weight bearing. If
yes.
you are weight bearing, the reverse will occur, which is essentially, and it's this is a weight bearing position is called a closed chain position. So if you are with your feet on the ground and standing up straight from a bent position, that's your knee is moving into extension, but because the foot is firmly on the ground, the tibia won't rotate. Instead, the femur will internally rotate at the very end of that movement. So it's
So our terminology is the opposite, the movement is actually the
the
same.
movement is the same, and the terminology, how we reference it, is somewhat different there. So
Yeah,
now,
good
the
point.
reason that that's important is during flexion movements of the knee, and this is what tends to happen, as you noted, during the downhill portion of that stance where you're decelerating your body, your knee is moving slightly into flexion. So as your knee moves into flexion, the tibia internally or medially rotates, and as it does, it pulls Gertie's tubercle around toward the midline of the body, and
Oh, I
that
can feel it.
increases. Yeah.
I can feel it in my left knee as you describe it.
Yep,
That's
that
interesting.
increases the tensile load on the entire iliotibial band, and then consequently, anything on the lateral side of the knee gets compressed actually against the bone in that position because you're sort of pulling those tissues taut across the protruding epicondyles.
Stretching and wrapping
Yeah.
around those bony prominences, yep, mhm.
Yeah, so this is one of the things as the anatomists looked at this, and the biomechanical specialists looked at this process. It changed at least some people's idea of the primary aspect of this pathology. Also, as you mentioned earlier, these anatomical connections from the iliotibial band to the femur make it less likely that the iliotibial band is rubbing back and forth across the femoral condyle because it's firmly anchored down there to the femur along its line. So there's not as much, side to side movement across the lateral epicondyles we might have once thought. But
Yeah.
there is a change in compression and relief of compression, relief of tension, compression, relief of compression during that flexion and extension cycle. And that may be what's irritating the underlying fat pad underneath there during those movements. And maybe there's just a little bit of that rubbing back and forth across, just maybe not as much as we originally thought.
Well, and I think this was a big, say, maybe it was a social media, but maybe it was more of a Twitter battle. But there was a lot of controversy around this question of, is it compression or is it friction? Is that band sliding around, which was the conventional story, or is it a compression of the taut band pulling against the bony landmarks?
Yeah.
And most of those discussions that resolved at least came to the idea of, well, maybe it's some of both, or maybe it doesn't matter. But there's an irritation for sure, and it's pain there for sure, with
Yeah.
probably compression factors and maybe friction factors as well, although
Yeah.
less perhaps than conventionally thought. It did, by the way, that did change the way I approached that lateral knee pain there.
So how does that
Because,
change for you? Tell me about
well,
that.
when I was thinking about the bowstring analogy, like let's say that long band as I imagined it at a netter crossing the knee there, and a compression there getting wrapped around the bony prominences, I would logically then want to, quote, lengthen the band or help
Mhm.
it be less taut so it pulled against those prominences less acutely.
Yeah.
If I start to think about it like a local irritation, perhaps, and especially with this idea that maybe it's attached along the whole femur, then it becomes more about local tissue response, sensitivity, and maybe hydration. So that my work, uh, realizing that the classic work of just say rolling the iliotibial band, or even like with a forearm snow plowing down the side of your leg there, uh, maybe there's less of a clear rationale for that than there would be for a lifting or a skin rolling, or even a hydrating idea of opening up the layers there to let fluids perfuse the zone and help resolve any local inflammation in the fat pad there or in the subcutaneous layers, and maybe increase tissue hydration so that there's more slide. So even if there is a friction aspect, maybe that stimulation of hyaluronic acid production with fibro, the fascia sites or something like that, whatever we're doing through either stretching or lifting, maybe that actually increases the tissue glide. So there's
Mhm.
less of the potential there for friction, as well as less of that inflammatory reactivity.
Yeah. So it kind of gets back to us talking about maybe trying to create the ideal environment for optimum function of those tissues, and like you said, making a little bit more capability for some the necessary level of appropriate slide and glide, but still maybe kind of, at least for me, my perspective is migrating away from this idea that we're doing something to the band
Yeah.
and making the band more extensible. Because if you go back and think about this mechanically,
Uh-huh.
the primary functional purpose of the iliotibial band is to maintain and increase knee stability, which means it has to pull on something firmly to transmit those tensile loads around the knee. And if something is really extensible and able to elongate from some forces applied to it, especially those kind of forces that we might apply with manual therapy, then it's going to be far less efficient at transmitting that tensile load down there to stabilize the knee. So
Right.
it seems like
You
it's
don't want
really,
rubber bands around your knee. You don't want rubber
yeah,
bands around your knee. You want something firm.
yeah, yep.
Gives
You
you
want
stability.
cables. Yeah,
Cables.
yep. So, but it has certainly spawned a profusion of commercial activities with things to do stuff to the iliotibial band, whether that's, you know, foam rollers or, massage tools or all kinds of things that people do advocate to try to work this band and soften it up. That's still quite a thing out there, and maybe that is the North American social media phenomenon that Robert Schleip was referring to, possibly.
Well, yeah, could be, but okay. Hmm, how much should I get into this? I mean, maybe the rationale of lengthening the band isn't really one that I go by in my work,
Hmm.
but that is a sensitive structure. The
Yeah.
entire side of the leg, and especially down at that distal end around the fat pad or whatever, highly innervated, highly sensitive. And it's sensitive in my mind because it senses. It's our lateral sensor. It's
Hmm.
the thing that tells us what our knee is doing, what our hip is doing, what our whole body is doing in standing, walking, running, etc.
Yeah.
And so there's ways that as a sensor, as a musculoskeletal fascial sensor, I'm really interested in bringing it into the body schema through my
Hmm.
work.
Yeah.
And sensation is one way I do that. Sensation is my paintbrush for the paintings I draw on the client's brain, as it were,
Yeah.
or the way I recolor their irritated zones of their brain or whatever it is. So
Hmm.
sensation is useful and it's a really sensitive structure. I will work it. But again, it's different purpose there, different idea. I'm not thinking of stretching it like a rubber band. I'm thinking about using its sensitivity to talk to the brain, to normalize the brain's reactivity or responsiveness to that.
Hmm. Yeah, and interestingly, along those same lines, one of the studies that I was reading was referencing a very high number of sensory receptor cells in that fat pad underneath the
Yes.
iliotibial band that was reading levels of compression of the band against the knee. And that's probably doing some things to help monitor the overall tension levels on that. And, I think we touched on this earlier, but I just want to reiterate for everybody thinking about the band, really, that the monitor that's changing those levels is the tensor fascia lata and gluteus maximus muscles. They're the ones that are giving the main pulling force to the upper level of the band that we can perhaps alter and change, that may alter and change the level of tensile load on that band.
Okay. So yeah, you're saying if we are interested in changing the compression forces there at the knee by reducing the tension on the band, maybe the muscle components, the upper end are the places to think about. And
Yeah,
that fits with my thinking and my approach too, for sure.
that seems to me to be the most likely place where we can make an intervention and have some kind of effects in there.
In fact, I'm saying that we should, this is a good opportunity. We should mention the handout we're putting together for this episode. And one of the things I'm going to put in there for sure is a tensor fascia lata technique with just that idea in mind, that we're actually changing the thing that pulls on the band-like structures.
Yeah. Yeah.
So that'd be one of the things I'll put in the handout from my side.
Yeah, excellent. So, and I think I've got a couple things I was going to put in there as well. So that'll be helpful for elaborating on some of these ideas.
Absolutely.
So, yeah.
What else you got, Whitney? What else you want to talk about?
Well, a couple other things that I want to mention just briefly. A couple things in particular that mimic iliotibial band pain and are often mistaken for ITB pain that people may jump in and try to do something about that can
Ah,
have pain in that area. And I'm always a big one on trying to distinguish and identify, what the primary cause is whenever we can, so that we don't, for example, do something inappropriate or we miss the mark and we're ineffective because we missed what was happening there. So couple things I was just going to highlight here. There is a pretty there's a couple bursa just on the lateral aspect of the hip, the trochanteric bursa, in between gluteus medius and the femur, as well as gluteus maximus and the femur. And those bursa can become inflamed and irritated and cause lateral hip pain that may be mistaken for iliotibial band pain.
especially if you scrimped on your camping pad from REI and you got a too
Yep.
thin a
Yep.
pad and you're sleeping on your side on the
And you're a
ground.
side sleeper. So that sounds like something from experience there that you have
Absolutely.
experienced.
Well,
Yeah.
and here in Colorado, I mean, I can't, there's been more than a few people, and it tends to be age related. Those of us, as the years go by, get
Mm.
more sensitive to sleeping on our sides, on hard surfaces, or that side of the hip seems to get more easily irritated from that, from just the direct pressure there,
Yeah.
probably on those bursal structures that you're talking about.
Right. So that would be one. Hopefully, we would pick a lot of that up in a history of something doing some kind of activity that would cause, pain and discomfort out there. There's also, some of the trigger point referral patterns from especially gluteal muscles, hip and gluteal muscles that may also refer down to the lateral aspect of the thigh and be mistaken for kind of aching kinds of pain along the iliotibial band region themselves. And I know sometimes I used to do this very early on before I learned a little bit more about the anatomy and mechanics. They would just try to go in and work all those areas where the pain was being felt, and that was just probably irritating some of the IT band because it's really, it's sensitive all along its whole length there to much pressure from
Okay, so
things.
this
Yeah.
is important. You're saying that sometimes somebody could feel pain, let's say in their lateral thigh, iliotibial band, and by working it, you could irritate it or make it worse. And maybe that is a referral pattern, you're saying, from gluteal
Yeah,
structures.
right. So you could kind of sensitize some of the neural receptors in that area from working something, and especially if you kind of take this attitude like, well, yeah, it's going to hurt good now, but we'll work this stuff out and we'll soften it up later on when that may not necessarily be occurring in there. So
Which is also an unhelpful assumption if there is any kind of inflammatory reactivity going on too.
yeah,
Like if there
yeah,
is some of that fat pad irritation or other sorts of things happening there,
yeah.
or a strain, a tissue strain.
Mhm.
Again, it might feel really good in quotes because it's giving some strong sensation there in the moment, but the question is what happens later? Does that
Yeah,
help it resolve or does it keep it irritated? Which, by the way, I got to stick this in. Sorry. This is one of the objections, say, to foam rolling, or one of the concerns about foam rolling. For one, the mechanical plausibility was questioned. Can you lengthen? If your goal was to try to lengthen the iliotibial band, can you do it with a roller?
hmm
Or even if your goal is to differentiate it, can you do it with a roller? I remember Greg Lehman's analogy of who do you say? Lengthening the iliotibial band is like trying to fillet a chicken with a rolling pin.
I like that. That's
But
good.
so probably not. You're probably not
Yeah,
lengthening or differentiating it. You're mashing it with with a roller. And in my view, maybe that's okay, except that if you just keep doing it and you keep irritating it, you keep something sensitized because it feels really intense and it has that kind of satisfying experience in the moment, then that could be, you could be keeping yourself in that situation, self-perpetuating pain, as
yeah,
it were.
right. So, and the other one I want to call attention to, and this is one that I sort of only a few years back became aware of as a prominent problem, and actually had this issue myself, and was kind of surprised to find the similarity and relevance. And this is compression of the lateral femoral cutaneous nerve, which is a moderately small sensory nerve that goes across the top part of the iliac, or the anterior aspect of the iliac crest underneath the inguinal ligament, and then supplies the skin over the lateral thigh, so directly over the iliotibial band. And it's pretty common to have compression of that lateral femoral cutaneous nerve from tight jeans, tight belts, or occupational, like a policeman wearing a heavy belt with gun and holsters and all that kind of stuff. And you can compress that lateral femoral cutaneous nerve and get this dull, constant aching pain over the lateral thigh region. And then you try to go in and work that area, and that's not going to get results, because that's not where the problem is occurring. The problem is occurring with compression right across the anterior aspect of the hip, near the inguinal ligament. So
you're talking about right at the ASIS and below, and
yeah,
fascinating.
Yeah.
Cool. So the stuff we wear could be a factor
actually,
as well.
And I found this getting irritated for me from some jeans that were relatively tight, and I was sitting a lot cross-legged in these relatively tight-fitting jeans, and that's what was squeezing my lateral femoral cutaneous nerve. And so I went through a period of saying, all right, I'm going to just, instead of wearing my jeans around all the time, I'm going to wear like sweatpants that are really loose, and then do some gentle, easy kind of myofascial or dermoneuromodulating type of skin drag techniques over the top of that lateral femoral cutaneous nerve to try to settle it down, try to make it a little bit more mobile and decrease the compressive loading across that area. And, found that to be like the thing that worked after years and years of trying to poke in on my TFL and, work on trigger points around the area, and found nothing really working with addressing other strategies for soft tissue involvement there.
Beautiful. So this skin drag was in the areas of sensitivity, or were you tracing the nerve anatomy, or how were you?
No, it was following the nerve anatomy, because the area of sensitivity was lateral thigh and down the thigh, and where I was working is right across the anterior thigh region, not at all where the pain was, but where the nerve is most likely to be getting compressed there as it's passing under the inguinal ligament across the anterior hip region.
And that skin drag, I assume, was really light. You weren't particularly digging.
Very light. Just
using a rolling pin.
Yeah.
Or, no.
No, it's just using fingertips and contacting the skin and pressing down in an inferior direction, just with a kind of a press and hold for a few minutes, let go, and then do some gentle movement. Just try to do that frequently. So that, in combination with decreasing the aggravating loads on there.
Was there any immediate sensory response on your part as your own client? I mean, could you feel it when you had it, or was it you using your knowledge of anatomy to mobilize those layers and you felt it later?
I would say both of those things that were true. What I felt when I worked it is like just this kind of sense of like, oh, yeah, that feels good. That just feels like it's just a little bit less irritable when I do that. It's just a sensation of feeling like that's the direction that those things want to be slightly moved or encouraged. So there was definitely a sense, interoceptive sense there, like, this feels good. This feels right. So yeah.
That's great. So then you could go back to meditating with your tight jeans on.
Exactly. Yeah.
No
But then I would be
that's why the monks wear robes. That's why monks wear robes, Whitney.
That's right. Yes. They know about LFCN entrapment, right?
All right.
Yeah.
And it's a good thing I took off my tight jeans and my gun belt before I sat down today, because we've been sitting here for a while. I would be having that going on if I hadn't.
That's right. Yeah. Yeah. So, and you got a couple other injury things too that you were mentioning that might be also related here. What else we got there?
Yeah, it's just worth bearing in mind the reasons. I kind of went through and brainstormed the reasons that I might go work this region of the body on a client. And injuries, as you mentioned, is one. There's people that will fall on their sides or have a scraping injury or a blow that can sometimes literally tear the that fascia lata, the wrapping that that band is a part of, and you'll feel like lumps and things like that in the tissue that can be really sensitized for a long time.
Yeah.
And I often found that I can help that sensitivity with direct work, thinking of glide, and again, changing the brain's reaction to that sensation there. I use it, again, this harkens back to my background as a rolfer. I use it for reduced lateral shift to the hips. So like, let's say, and we go into this a lot in one of our workshops in particular, let's say someone takes a step and they shift their shoulders over that standing foot as opposed to their hips. You could either be Marilyn, this is the chapter I wrote for Eric Dalton's book too. You could either be Marilyn Monroe and shift your hips over that standing foot, or you could be John Wayne and shift your shoulders over there.
Oh, interesting.
Yeah.
Yeah.
So John Wayne isn't lengthening his iliotibial band. He isn't allowing it to lengthen.
Uh-huh.
And that's all Marilyn is doing. She's just getting really long there. So there is that continuum that I'm looking for, that ability to shift some of your weight over the standing foot,
Yeah.
that I will work that side of the body. And it comes from that thinking of we're going to help it lengthen. And yet my rationale for that has changed. I'm thinking, okay, so the brain is allowing that structure or that line or that part of the body to adapt and to allow the shift more than, like, say, making it more rubber bandish,
Yeah.
making the body more willing to shift in that direction.
Yeah. Let me pose a question to you because of your specialization in working in sort of myofascial perspectives here. You know, there is a pretty strong anatomical connection we found in fascial connective tissue between opposite side thoracolumbar fascia and gluteus maximus on the opposite side. So when we think about the gluteus maximus transmitting a lot of tensile load into the iliotibial band,
Yeah.
would it make sense to then focus? Let's say a person's, left iliotibial band is bothering them. Would it make sense to include addressing thoracolumbar fascia on the right side of the body because of the connectivity across those sides there?
Yeah, I can see the rationale. I think in my style, I tend to be more empirical than theoretical.
Mm-hmm.
Rather than mapping out the line of where it would connect, I tend to follow my immediate perceptions, and especially the client's reports of
Yeah.
what changes as we work along it. But certainly if I wasn't getting the results I wanted, I might pull on some different theoretical models to think, okay, so where else farther up the body might this be connecting?
Yeah.
After you've crossed a couple of joints, it's almost like, in my mind, it's less about lines and more about branching connections,
Mm-hmm.
because everything is so interconnected
Yeah.
that it's a little hard for me to predict, like down the leg, like, say, where exactly in the back this might be connected to.
Yeah.
I will find places all the time. I think those connections happen, but it's less predictable. And it's just as likely, say, that it's the same side as the opposite side, or that it's around the front, or who knows what it is.
Yeah. Yeah.
And so it makes
And I
sense.
think you mentioned this to me once before, or possibly in one of our earlier discussions, to the idea of these sort of connections in all these different places. You have a pretty significant degree of force dissipation anytime that there's something that branches off from that connection, that some of that
Mhm.
pulling is then distributed or dispersed to other adjacent tissues around there. So there may not be as strong of a transmission all the way from one distal
Mhm.
location or distant location to those particular tissues there.
Yeah, maybe not as strong and certainly not as specific. I
Yeah.
mean, there's definitely exceptions. You'll find,
Hmm.
like, there's all those amazing stories about, "Oh, he worked my knee and my jaw was suddenly free."
Yeah.
Those that really happen, but the mechanism is sometimes maybe up for debate and maybe not always replicable. Like,
Yeah.
now I'm gonna go work everybody's knee who has a tight jaw. I don't know. I don't know if there's a
Yeah.
rationale for that.
Right. Yeah, we
So
tend to, I know me and the way I look at things, and a lot of other people will probably tend to default to looking at biomechanical explanations for something like that. And those things have frequently perplexed me in trying to figure out what
mhm.
on earth is occurring there. And then maybe it's something as, you know, bizarre, even as, we had that episode, I can't remember which number it was, when we talked about the homunculus
Yeah.
and the relationship of the brain's patterns of the body, and maybe it's
Yes.
just a homunculus relationship in there as opposed to a direct causal effect mechanical thing in there.
That's a narrative that works for me. That seems to
Yeah.
explain a whole lot,
Yeah.
and again, whatever narrative gets you through the night, or, whatever it
Yeah.
is that helps you doing your work and get the results you want.
Right.
Fine.
Just don't build a system around it for everybody that you think is gonna it's gonna fit everybody and create the homunculi technique or something like that.
Uh,
Right.
right, yeah. Oh, boy, I
So
didn't think of that. Maybe I should have done that before you told me not to. Too
that's
bad,
right.
but I won't.
Yep. Our secret. I'm sure nobody else heard that. Right.
Yeah, right.
So,
So
all
I
right, what
think
else you
I
got there?
No, I think I covered it, like how, where, And to what end do I work with the iliotibial band? Basically, it's that lateral hip shift, which is essentially femoral adduction, but it's like,
Mhm.
can the hip shift over the foot? Lateral knee pain, that's my go-to, is that side of the leg there. And maybe the hip, those things you said could be mistaken for iliotibial band syndrome. I'll still work that region,
Mhm.
not assuming I got the mechanism, but more like I'm looking for a doorway into that complex.
Yeah.
I'm thinking, is
Mhm.
there something here I can find that shifts the client's experience of
Yeah.
that sensitivity?
Yeah. And I think that just sheds additional light on our kind of holistic perspective of looking at the body and just saying, we're not just going to deal with these individual pieces here, but we want to look at the overall person's experience of the intervention that we make and how does that change their feeling of what's going on in their body as well.
That's a good summary. I like
Yeah.
it.
Okay.
Well, I'm going to put my three or so techniques into the handout. We're going to get some cool stuff from you. Anything else you want to say in wrapping it up there, Whitney?
Um, I think that's kind of a good dive into some interesting dilemmas and things to ponder and think about with the iliotibial band. So I think we're still learning a lot about it, its function, how it works, and how we can intervene with things here. But there's some good things to chew on, I think, with what we've gotten into today.
No, I appreciated some of those details that you helped fill in my map as well.
Mm.
And it's fun to talk to you as always.
Yeah.
We mentioned the handout. I should have done a commercial sooner for our upcoming leg, knee, and foot principles online class that starts early September. The
All right.
first orientation, yeah, our first orientation is September 8th, but you
Hmm.
can start anytime up to September 15th or so and get the whole course. Or it'll be available later by recording, but really invite the listeners here to come join us in that course because we get to go through in detail our set of advanced myofascial techniques for the leg, knee, and foot. And it's a hybrid live and slash online format. It's all done online rather, but it's a hybrid of recorded and live real-time input with small faculty groups and lots of interaction as well.
Great. So people can ask you questions and things like that in the
Mhm.
midst of the presentation thing.
That's right. In fact, that's been
Yeah.
the richest part of it is the in-depth discussions we have time to get into in this format. We're going in for a weekend workshop. We would get through the material and give people great techniques, but now we're really finding we can unfold the principles or the ideas behind the work
Yeah.
here.
Yeah. That's one of the things that I love about that environment and too is, the flexibility of time limitations. You can also, because you're not just limited to the 16 hours of the 2 days that you're together in many of these kind of situations, you can come back and ponder things and bring up other questions of things that come up. So,
That's right.
I hope to see some of these, pandemic inspired hybrid models and experimental educational models that people have been working with for a while, hopefully expand some of our methods of doing educational things. That's one of the things that's exciting to me of what's coming down the pike.
Yeah, me too. Me too.
Hmm.
So I hope you join us in September.
Yeah.
I should also mention our closing sponsor, and this is Handspring Publishing, who helped me publish the book I wanted to write. Even though I had offers from a large media conglomerate, I chose them, and they are run by four great people who love these great books about our field. And I'm still glad to this day, many years later, to choose them because their catalog has emerged as one of the leading collections of professional level books written especially for body workers, movement teachers, and all professionals who use movement or touch to help patients achieve wellness.
And Handspring's Move to Learn webinars are free 45-minute broadcasts featuring their authors, including one with you, Till. So head
Yep.
on over to their website at handspringpublishing.com to check those out and be sure to use the code TTP at checkout for your discount. And we thank Handspring once again for their sponsorship of the podcast. And a thanks to all of our other sponsors as well. You can stop by our sites for show notes, transcripts. Like Till mentioned, we have a handout on this particular episode here and any
Mm.
other extras over there. So you can get links to that from my site at academyofclinicalmassage.com. And Till, where can people find links to that from you?
Advancedtrainings.com, advanced-trainings.com, where actually we found out it works even with just advanced trainings, no dash. It goes to the same place.
Oh,
If you
cool.
got questions or things you'd like to hear about, just email us both at info@thethinkingpractitioner.com or look for us on social media. just my name, Tiluka. What's yours, Whitney?
And you can find me also on social under my name, at Whitney Louw as well. And you can follow us on Spotify, rate us on Apple Podcasts. And if you do drop a review over there, that does help other people find the show. So we really do appreciate that. And we want to say a thank you to all of our listeners and people who've been hanging out with us, listening to our discussion. I hope you're getting some good things from that. So you can find us those locations, and then also wherever else you happen to be listening, and do share that and tell a friend. And of course, as always, if you are unable to find it in any of those locations, you can aim your underwater sonar dish at the South Pacific, and you'll hear us emanating from the deep recesses of the Mariana Trench as well.
We get like email from everywhere. That's amazing.
Yeah. So it's great. Thanks for listening, everybody. So we will see you again in a couple weeks and dive into some other interesting things to chew on at that time.